In the past 15 years, lung cancer treatment has changed significantly. The first thing that happened was the discovery of targeted therapies. There is a group of patients who have a special type of lung cancer that can be treated with pills, with targeted therapies. And those patients are usually never smokers, but this can happen in smokers also. Their lung cancers are generally thought not to be related to tobacco. And so for that segment of the population, this treatment is significantly better than chemotherapy. The difference between targeted therapies and traditional chemotherapies is that targeted therapies really are going after the specific cause or the specific molecule that is abnormal and producing the cancer. Chemotherapies are just designed to kill cancer cells or any cell that's dividing rapidly. It's not going specifically to the cancer. It's just a toxic drug that kills any cell, including normal cells that are dividing rapidly. Targeted therapies are appropriate for patients who have those activating mutations or changes in the cancer cells that can respond to those targeted therapies. So patients who have the target. Patients who don't have the target, the patients with the regular tobacco-related lung cancer, generally don't respond to these drugs, and so we don't use them for those patients. When we find patients with mutations, we look at each specific mutation, and these are EGFR, ALK, ROS1, BRAF, BRAF, and RET, RET. And we talk about all of the drugs that are available for each of those mutations. We talk about some of the clinical trials that may suggest which is the best drug, or we look sometimes at their toxicity profiles, how much they produce in terms of side effects, and discuss that with patients to see if that gives us a specific direction in terms of which drug to use. But we always choose the best drug looking at efficacy and looking at safety or toxicity. Targeted therapies can act very quickly. It's not uncommon for us to see patients whose symptoms have disappeared within a week or 2 weeks or even 3 weeks of treatment. And so we often know whether drugs are working even before we do the first scans. CT scans, MRI, PET scans, these scans can tell us whether the tumor is shrinking. So the treatment with targeted therapies has changed over time since we first discovered these mutations. One of the most important things that has happened is that we are now developing drugs to attack specific targets or mutations that may arise after the first targeted treatment. And so when these drugs stop working, we now have other third-generation drugs, and we are developing subsequent generation drugs that may affect or may attack even second resistance mutations. Genomic testing has significantly changed how lung cancer is treated. In those patients who have activating mutations or changes in the cancer cells where we can use targeted therapy, the outcome is significantly better. And so for that population of 15 or 20% of lung cancer patients, this has changed their life significantly.